Good evening, everyone. Respected Chairman, Dr. Rajesh Jagannath, doctors, and invited guests. It gives us immense pleasure and privilege to welcome you all this evening for Cardia Laureate Award ceremony and the scientific session. Let us begin this auspicious occasion with Tamil Thai Valthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Please be seated. Light symbolizes knowledge, wisdom, and positivity. To mark the formal inauguration of this scientific meeting, I invite our chairman, Dr. Rajesh Jagannathan, Dr. V. Ramamurthy, Dr. Shanmuga Sundaram, Dr. Mohan, Dr. Veena, Dr. Shakti Sukanya, Dr. P. Vinod Kumar, Dr. Ilayaraja, and CEO Mam Satya. Thank you, respected dignitaries, for illuminating this evening with your presence. We now move to the most awaited segment of this evening, the Cardiac Laureate presentation, honoring their excellence, dedication, and outstanding contribution for their educating the younger generation of cardiologists. I invite our chairman, Dr. Rajesh Jagannathan, to present the award shield. I invite senior cardiologist Dr. B. Ramamurthy to present token of appreciation and shawl. Please come to the stage. I request Dr. K. Narasimha Reddy sir to come to the stage. Dr. K. Narasimha Reddy, the first to start angiography in South India when he started his career in Railway Hospital, the most hardworking, the most patient-friendly, and the most innovative in coronary intervention. He is an expert in deciding when to stop during interventions and when to avoid interventions and refer for the surgery. He works 12 to 14 hours a day, all day a week, and extends his professional help to needy patients in Nellore and Tirupati as a matter of service throughout outreach clinic in uninterrupted manner. Thank you, sir. I invite Dr. Allegation to please come to the stage. Dr. Allegation, the first to start echocardiography in India in 1979, trained most of the echocardiographers in this country and adjoining nations, a passionate teacher and leading expert in echocardiography in Asia. He has the largest collection of echo cases in this country. Despite having in-depth knowledge, he does not hesitate to learn new things and update his knowledge on day-to-day basis. Thank you, sir. I kindly request Dr. Shiva Kadaksham to please come to the stage. Dr. N. Shiva Kadaksham, a kind-hearted, very cheerful and humor-loving doctor, but at the same time serious and attentive in work. An excellent clinician who could make diagnosis of complex disease accurately even in pre-echo era. He learned echocardiography and intervention all by himself and trained hundreds of youngsters in Tamil Nadu. Though a doctor of many VIPs in the country, his priority is for those who are resource limited. Thank you, sir. I invite Dr. R. Bharat Kumar to kindly come to the stage. Dr. R. Bharat Kumar, the most ethical and cost-conscious cardiologist of this country, firmly believes that the modern treatment should be available and accessible for all the community irrespective of the resource. A very straightforward and down-to-earth person. His treatment decisions are dictated by science and his rich experience. A man of rigid principle, despite of having 5 doctors in his family, he provides untiring service to those who is outskirts of city day and night, even now. He is so sincere that he never leaves home if a sick patient is in the hospital. He is completing his 50 years of service in community where he is practicing. Thank you, sir. Congratulations to cardiologist. Thank you, Dr. B. Ramamurthy, sir. Now I request Dr. Shanmugasundaram, sir, to honor the award and shawl. I invite Dr. Muralidharan to please come to the stage. A man with bubbling enthusiasm from learning and teaching. He is loved by his teachers, friends, and students for his positive attitude. An innovative thinker, loves both bedside medicine and advanced cardiac procedure equally. With his own efforts, he has become a skilled electrophysiologist and interventional cardiologist all by himself. Lover of Tamil language, writes poem in Tamil and English. He is also an excellent music director. Thank you, sir. I request Dr. Asha to kindly come to the stage. Dr. Asha, the first woman interventional cardiologist of Tamil Nadu, able to devote time for teaching and research, despite of being busy with office practice and interventional practice for nearly 3 decades. In addition of being an excellent homemaker, she is a South Zone Executive for Women in Cardiology and Related Science Forum. Thank you, ma'am. Congratulations. Thank you, Dr. Shanmugasundaram. I invite Dr. Mohan to present shawl to the awardees. I invite Dr. Murali Krishnan to come to the stage. Dr. Murali Krishnan is one of the most accomplished cardiovascular anesthetists in this country. Having a special skill of ECMO, he is known for his calm problem-solving approach while dealing with crisis in the critical care of sickest patient. He has in-depth knowledge and skill to provide advanced intensive care for management of complex heart and lung transplant. He never says no when his help is sought and never hesitates to impact knowledge to his colleague. I request Dr. Mohammad Yusuf to come to the stage. I invite Dr. Kannan to the stage. He is the best and most trustworthy administrator among the cardiologists of Chennai. The way in which he conducts the All India Cardiology Conference in Chennai few years ago speaks for his capacity and ethical standard. He spends most of his personal time and effort to uplift the Department of Cardiology in government hospitals. He had done marvelous things in Stanley already and continues now in Madras Medical College. We are sure that he will uplift the image of Government Institute in such a way that even the rich will start preferring government hospitals. Thank you, sir. I invite Dr. J. Cicely Mary to collect the honors. The most dynamic all-rounder in cardiology during clinical medicine, imaging and intervention with equal interest. Her original research works are receiving attention from Europe and USA. An excellent speaker in many scientific meetings of this country and abroad. An active member of Women Cardiologists Forum in this country. She effectively balances family commitments and professional commitments. Thank you, ma'am. Congratulations, sir and ma'am. I kindly invite our international faculty, Dr. Kamlesh, to the stage. Chairman, Dr. Rajesh Jagannath, sir, will now present the memento and token of appreciation. I invite Senior Consultant, Cardiologist, Dr. Shanmugasundaram, to facilitate with shawl. We invite our doctors, our true partners in growth, to the stage. Thank you for traveling this path of excellence with us. Please accept this honor as a mark of our respect to Dr. Kumaran sir. Dr. Kumaran sir, please join us on stage. Thank you, Dr. Kumaran. I invite Dr. Balaji Pandian sir to the stage. Thank you, Doctor. Thank you, Dr. Rajesh Jagannathan, sir. Our chairman is the architect of our institution growth, balancing a profound commitment to the patient with vision of future of healthcare. Under his guidance, Billroth Hospital has become more than a medical faculty. Thank you, sir. May I now request everyone to kindly rise for the national anthem.
जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I kindly invite Dr. M.M. Yusuf sir to the stage. Dr. M.M. Yusuf sir, a skilled cardiac surgeon who is devoted to establishing minimal access surgeries and robotic surgeries as in cardiac surgeries in India. He is the most wanted doctor for the same across the entire nation and nearby countries of South Asia. He is also an expert in major aortic surgeries. He has the pride of having performed maximum number of robotic cardiac surgeries in the country. He has done over 500 surgeries and he is well known as a pioneer in this field. Thank you, Doctor. Thank you, sir. We now move to the CME session, an integral part of today's scientific meeting. I invite the chairpersons, Dr. K. Kannan sir, Dr. Asha Mahilmaran, Dr. Cecily Mary, Dr. Kumaran, Dr. Balaji Pandian, Dr. Murali Krishnan, Dr. Mohammad Yusuf to occupy the chair and conduct the proceedings.
Good evening to all of you. I am Dr. Sivakarasham, cardiologist, and a good friend of most of the cardiologists and cardiac surgeons in Chennai. On behalf of all the people who had received the Cardiology Laureate Award, I would like to first thank Dr. Rajesh, who has got a kind and broad heart to felicitate all of us. Thank you, Rajesh. Next, I would like to thank my colleagues Shanmugasundaram and B. Ramamurthy, who had carefully selected the cardiologists, cardiac surgeons, and the cardiac anesthetists, who are all part of the growing cardiology today, and they have beautifully selected the people. Of course, with a bias, he has selected me because he worked with me for a very long time. And most of us have been the product of Professor Sivarajan, starting from me, followed by Shanmugasundaram, Bharat Kumar, T.R. Muralidharan, and most of us have been trained by him. And we thank him for having guided us to promote cardiology in the right way. I thank you all for having come here to attend this. Thank you.
Speaker. Good evening, friends. It's an honor to be here and be an awardee in this among the stalwarts of cardiology. And I thank Dr. Rajesh Jagannathan of Billroth, Dr. Shanmugasundaram sir, Ramamurthy sir, and the entire Billroth cardiology team for honoring us and keeping us on stage and giving us an academic platform as well in the CME, which is going to mainly on cardiogenic shock and how we are going to manage what is really a cardiogenic shock, what are the contemporary what is the contemporary science behind it, the hemodynamics and the management of the devices. So the first, we'll start the topic with the first speaker, contemporary management of cardiogenic shock. I call upon Dr. Kamalesh Anbalagan to come on stage. Welcome, Dr. Kamalesh, and it's a joy to have you here with us. And the topic is contemporary management of cardiogenic shock. Over to you.
Okay, thank you everyone for attending this, and it's really a big honor for me to be here and to be speaking on a topic that's very near and dear to my heart. And I didn't realize there's so many legends of cardiology in India is going to be around as well, so it's really a treat and pleasure for me. Let me see whether I can get my slides on. Okay, so this topic, cardiogenic shock management in critical care, is something really near and dear to my heart. It is something that I do 26 weeks a year, right, 24/7 during that time, and patients come in, at the most inconvenient time, really. I have no conflicts to declare, so this is not going to be really directed towards any device or any procedure, but really the management of cardiogenic shock. So earlier, when we did the roundtable discussion on creation of cardiogenic shock protocols, one of the things that was highlighted is that cardiogenic shock is a highly heterogeneous disease. This is why, for an intensivist, it's very fun, because patient A, patient B, patient C all will present very differently. And if you look at the papers that come out on cardiogenic shock, they try to kind of give you a workflow, a framework. So they tell you sky staging, right? Tells you how sick the patient's severity is. They will tell you about hemodynamic profiling, phenotypes. They will say things like cardiometabolic shock, which basically just means there's multi-organ failure involved. But down on the ground, when you are seeing this patient, when you're managing this patient in the ICU or in the A&E, what are the granular steps that you need to take? Right, so phenotyping by etiology is very common, right? People divide it based on whether it's MI, heart failure, whether it's post-cardiotomy, secondary CS. Again, generally speaking, not particularly useful on the ground, but the data shows that if you have AMI CS, the mortality is higher than heart failure CS because your body doesn't have time to adapt. So there are some uses in phenotyping, but in the end of the day, again, how do you use it on the ground? So phenotyping by hemodynamics is very commonly done in the cath lab. It's also done in the ICU, and it really guides therapy, right? It's not really just to make a diagnosis. The patient has MI, the patient's blood pressure is low. It's not difficult to make the diagnosis, right? But what you're going to do, what is your next vasoactive? When do you choose a certain MCS? That's when the hemodynamic phenotyping is very useful. Now, sky staging is the severity, like I mentioned before. It's very useful as a language of communication. So when my center started to use sky staging as a language of communication from 2024, it was a lot easier for people to understand with much less words spoken. So it really gives a little bit of an idea of how severe the patient is, how fast you have to intervene. So let's start off with a case example, right? So 61-year-old female, Mrs. Ravi, she has, multiple cardiac risk factors coming with anterior MI, EF 20%, lactates already elevated, so we know perfusion is a problem. PCI was done promptly, dual vasoactives given, and the patient is now back in the CICU with a MAP of 69, right? Heart rate is 100, respiratory rate 27, SpO2 93%, creatinine is elevated, likely there's some degree of acute kidney injury, ALT is elevated, so we know there's a cardiometabolic component, and of course there's some degree of acidosis. Pretty standard, right? We see these cases quite often, about 5% of MI cases present this way. So the question a lot of times is, what do we do at this point, right? So we know it's AMI-CS, right? So we phenotype by what the cause is. We know it's Sky Stage D, okay, great. We know there's no big difference in terms of, no contraindication in terms of usage of temporary mechanical circulatory devices. So what would you do? Right, so in the past, many people will say, look, wait, we have done revascularization, let the myocardium recover, right? We support the organs. Some will say, look, this is cardiogenic shock. SVRI is going to be high, cardiac output is going to be low. Let's start dobutamine or milrinone, right? And there are trials that are done on this, right? Dobutamine versus milrinone, dobutamine versus levosimendan. So again, is it so cut and dry? Is this really a cookie cutter kind of treatment for cardiogenic shock? Would you insert an IVP, right? We know the trials say it doesn't work. would you insert a PA catheter for every single one of these cases? Would you do CRT, there's AKI, there's congestion, or would you go for ECMO or impeller? So a lot of times, if you use Western protocols, you'd realize that upfront, the utilization of a lot of these MCS devices will go up tremendously. And the cost of doing that is a lot, right? It's going to be a huge problem. So again, you need to decide which patients you're worried about, which patients will recover. And this is one of the key slides that I have, and it's actually alluded to in the guidelines, is that refractoriness is actually the most important thing. And you need to learn how to assess the refractoriness. So the guideline says, for example, there's no need to fail medical therapy before escalating MCS, right? But what do you mean by fail MCS? What do you mean by medical therapy? That has to be granular, right? It is not clear over here. So what we know is if a patient starts off with SCAI stage B and moves on to C, D, his prognosis is going to be a lot worse as opposed to a patient who starts at D and is now moving up to C, right? And the most important thing is that you need to reassess the patient, right? And we will talk about this granular detail, not just some idea of how you reassess the patient and you decide what to do next. So the clinical assessment is important because if you don't, and you just say, I'm going to MCS everybody, you're going to have a lot of problems. You're going to go bankrupt. Your system is going to go bankrupt. Number two, if you allow physiology to declare itself, that means medical therapy to fail, then you put MCS, also a problem. Because then what happens is that you're going to have multi-organ failure. You will still end up putting MCS, right, because the patient is a candidate for it, and the outcomes will be poorer, right? It's not the device's fault, but it's because you put the device in too late. So early upfront MCS seems to be an easy solution, but like I said, it's not what it's cut out to be, right? So practically, what you need to understand is you need to ask yourself, what are you targeting when the patient comes to you in the ICU, right? So the biggest problem I think that's present in most ICUs is that we look at blood pressure as a surrogate for cardiac output. And I think this is really the biggest problem. And the moment you do this, you're really flipping a coin. So what is more important is that, is organ perfusion restored? Because that's the role of the cardiovascular system, is to deliver oxygen to the mitochondria of the cell so it can do its job. If you don't deliver that, then that cell will not do its job, it will start to fail. So is organ perfusion restored? Congestion is another thing which I'll show data later, increases mortality significantly. And the way we manage medical ICU or surgical ICU patients, right, as a cohort, is very different from what you would manage in a cardiogenic shock patient, right? And what support you will need if, let's say, you're not able to restore this. So how I manage my ICU, right, is I look at supply versus demand, right? So the demand is clear, right? The body needs to produce, deliver enough oxygen to meet the demands of the tissue, right? So the VO2 is the demand. The supply, we all know from our training days, is the DO2 equation, right? So it includes hemoglobin, it includes cardiac output, and of course it includes your SaO2, right? So these are parameters that you can vary to try and meet the VO2 requirements. And critically ill patients, the VO2 requirements go up 30, maybe 50%. So how do we know this? Keep it simple, right? So we know demand, right, by looking at things like lactate, things like CO2 gap, things like SCVO2 or SVO2, your urine output. Supply, the one that's really the most useful is going to be your cardiac index and your CPO. In reality, we look at other parameters like SVRI and all that. Oops, sorry. Okay. Was the previous slide seen? Like, was this slide seen? This slide was seen, okay. Sorry about that. Okay, so CO and CI tend to be easier, more reproducible, as opposed to things like SVRI and all the other parameters that you may potentially see on a PA catheter. Keep it simple, basically. Right? And if you look at this table that I used to manipulate different numbers, you see that cardiac output provides the greatest increase in the DO2, the supply. Hemoglobin, really, you can't adjust it too dramatically, right? You can individualize your targets, right, of your hemoglobin targets, but it's very challenging in a congested patient. SaO2, generally, most people would go for as high as they can, and that being 100%. So cardiac output is the main thing that you would vary. So what do I do? So step one, I examine the patient. Now this is extremely important. We always think about the sexy stuff, but actually, how is the patient looking? Is the patient alert, looking well, right? How is the peripheral perfusion? What's the cap refill? What's the urine output? Now, why is this useful? Because you even see in the Andromeda shock trial, which is a septic cohort, simple things actually do work, right? When they compared it with PA catheters and more complicated ways of assessment. So, an example, right? So we see myocarditis patients once in a while. Young female, 30 years old. Their presenting complaint tends to be a little bit of abdominal discomfort, lightheadedness. Abdominal discomfort really because of mesenteric ischemia that comes with the low output state, right? And you will see that they are a little bit not straight, right? When you speak to them, they are a little bit dazed. It's not normal for a 30-year-old, right? And you see the cardiac output is very low. So even if the blood, and a lot of them, their blood pressure initially is normal, a little bit tachycardic, but this person is in proper shock, right? Even though the blood pressure looks normal. So this is very, very important. Examine the patient, see how they are physically. If they look alert, they look better than they were before, sometimes the biochemical factors lack a little bit. Number two, is the MAP target hit? So remember, I told you, using pressure as the most important target is not good. But you also cannot say, I'm not going to care about MAP. So your nurse will kill you, right? Tell you, oh yeah, MAP is 40, it's fine. You can't do that. Right? So we know the auto-regulatory threshold is about 60, and it's a lot of it from a survival sepsis guideline, and that's the reason why we use 65, right? We can't live in the border. And we know again from sepsis guidelines that the MAP of 65 tends to do well. Now, trials again have shown that if you try and individualize blood pressure, higher and lower, but again, not really individualizing, you're looking at a population level, not a big difference, right? High blood pressure versus low blood pressure. But subgroup analysis, and again, subgroup analysis have its own flaws, but it does show that the kidney, which is also a reflection of perfusion, those patients, for example, with chronic hypertension, where the autoregulatory curve is shifted to the right, you can see that higher blood pressures do result in less AKI. So the question now I have for everyone is BP a reflection of cardiac output? And I can tell you a lot of us have this bias, right? So if I give you this picture, it becomes very obvious, right? A guy, fit, cross-country runner, blood pressure 120/80 versus elderly 90-year-old female, 170/60, who has a higher cardiac output. So blood pressure is not a marker of cardiac output. So we know, again, when we talk about blood pressure, there are different aspects of it, right? There's systolic blood pressure, there's diastolic blood pressure, there's mean arterial pressure, very many different components. And it really is an interaction between the pump, which is the heart, and it's the blood vessels, right? So the arterial tone is very important. So a nice compliant blood vessel, when the heart ejects, it accommodates that flow, right? It expands, stores the energy, recoils back, and that gives you your diastolic pressure. And what is important to understand is that if you have an older, stiffer vessel, right, you have a very high upstroke in systolic pressure, but your diastolic pressure is going to be lower. Right, so when you manage these patients and when you give them vasoactive agents or when you give them fluids, you need to understand it's not just the interaction between the heart, but it's also the interaction with the blood vessels. So BP is not equals to cardiac output, and BP is not a single number, right? BP can be systolic, diastolic, mean arterial pressure, pulse pressure. Huge number of difference. And in the end of the day, the mean arterial pressure is a combination of your resistance as well as your cardiac output. So why is this important? Because in the end of the day, this ventricular arterial coupling is actually very important. It's very difficult to assess, but the concept of it is very important. And there are actually simple ways to assess the tone of the patient, right, without actually doing complicated assessments. So I always teach the trainees about the resistant bike. So any of you have gone to the gym and you've used a resistant bike and you put resistance at 0, you realize that it's very challenging to cycle, right? You're using a lot of energy, you are pedaling away, but it's very tough. You have a lot of issues, and you're not able to reach the RPM that you want. Once you crank up the resistance a little bit, you realize that you are now in optimal kind of exercise. High RPM, high speed, very little energy expenditure. But you continue cracking up, then what happens is that you start to realize that it's very difficult for you to pedal, you're struggling, and that's afterload. So ventricular arterial coupling is very, very important. How can you assess that simply at the bedside in the ICU? So again, like I mentioned to you, it's very hard to assess simply because the baroreceptors and chemoreceptors try and keep things at a very, very fixed set point. So it's very challenging, right? But in physiology that is deranged, it can be assessed. So blood pressure below 60-65 is generally a poor marker of perfusion, right? Generally speaking, and that's what the data shows. But there are more to blood pressure than just that. Look at the diastolic pressure, interpret it in the context of heart rate, and it will give you a lot of information even without the PA catheter. So I'll give you an example. So you see a arterial tracing here, right? So if I increase the heart rate of this patient, right? Slides not moving. So let me go back here again. So if you look at this patient, right, so if the heart rate goes up, you realize that your diastolic blood pressure goes higher, right? A diastolic blood pressure is a good marker of your tone, and the body's response to maintain a higher diastolic pressure is usually tachycardia. So if you see, again, two patients, so patient A, patient B, is scenario number 1. MAP 92/55, MAP 67, right? Another patient, patient B, 111, blood pressure 45, MAP 67, right? You would think that both patients have the same vascular tone, but the one with the lower diastolic pressure is the one you're going to be worried about. Because if you're going to start an inodilator for this patient, what's going to happen is that you're going to have an inotropic effect and you're going to have a vasodilatory effect. Right, so for this group of patient, I will be very careful about starting a inotrope like dobutamine. Because if the heart is very weak, right, there's not much beta receptors there, a lot of it's scar tissue, you don't get much increase in your cardiac output. And those of you who put PA catheters very often, and when you up titrate the dose of your dobutamine, you realize that the cardiac index doesn't jump from 1, to 2. It goes up by maybe 0.1, 0.2. Right, and the higher you go, you realize that the increase doesn't commensurate. So it's very important to understand what the vascular tone is. So if I were to start dobutamine for patient A, they may do okay, but for patient B, the blood pressure may fall first, right? And it's a very hard concept to understand, right? Because you think, hey, if I start norepinephrine, why would the patient be better? But actually you are coupling that patient better. Now, again, patient A, patient B, so you can see same blood pressure numbers, but you can see that the heart rate is different. So in patient A, right, you know that if you slow down that heart rate, that diastolic pressure is on the floor. So if a septic shock patient comes like this, I would start norepinephrine very early. I don't flood them with as much fluid as I would. Patient B, on the other hand, the heart rate is more normal. Then at this point, yes, you can try giving a bit of fluid because their diastolic pressure is not as impressively low as patient A. So this is a very simple thing, right? So what I do, so if I have scenario, patients come in like this, right, what do? I calculate what is called the diastolic shock index. I take the heart rate, I divide it by the diastolic pressure, and I see how high that number is. The higher that number is, I know more vasodilated the patient is. Right? So that would affect your initial vasoactive therapy. Right? So when you give an inodilator, again, I want to make this point, does the heart have reserves? So I've had patients where the patient's primary pathology was severe aortic regurgitation. Right? The heart muscle was otherwise fine. The coronaries were not occluded. When I start dobutamine, the increase is very dramatic because there's some contractile reserve. But we also have patients with very bad ischemic cardiomyopathy. I start dobutamine, nothing moves. In fact, blood pressure falls. Right? Beta blockers obviously affect the amount of beta-1 receptors. And once you have cardiometabolic shock, meaning you have multi-organ failure, you realize that your vessel starts to dilate. Because the vessel didn't study the textbook, right? So once it starts to die, it produces your cytokines, it causes vasodilatation. Right? So in cardiometabolic shock, you tend to have a higher degree of vasodilatation. Now, again, is there anything in the literature that says and favors one drug over the other? Not really, in terms of inotropic support. And what I would say is that if you're going to give drugs like milrinone, and you're going to give it for long durations, if your kidney function is not good, it's going to accumulate, and it can give you problems with arrhythmia. Levosimendan, the biggest problem is that it's very long-acting. So it's its strength and its weakness. Because if the patient gets sepsis, you're in trouble. I've had a patient before where we gave levosimendan and went profound vasoplegia. We couldn't find a reason. There was blood cultures done, he had no fever. The only thing was levosimendan was given. We had to wait out a week before the blood pressure went back to normal. We didn't do anything special. So afterload is always a concern when you read the textbooks. It says, look, afterload goes up, right? Patients will have, the heart is failing. Not necessarily true. In fact, what I will say is that 75% of patients in literature have shown that they do not have very high SVRI. In fact, my own experience, we do about 30 to 50 PA catheter runs for cardiogenic shock patients in a year, and I can tell you majority of them don't have a dramatically high SVRI, right? So most of them have either normal or low. And if you really read down to physiology, you will know that SVRI itself tends to be an overestimate of the true critical closing pressure. So those of you interested, you can go and read about the waterfall theory that was talked about even in the 80s by Michael Pinsky, one of the physiologists. So it is very important to understand that not all cardiogenic shock patients have vasoconstriction as you may think. The longer they are in shock, the more multi-organ failure there is an element of vasodilatation that happens later. So we have talked so much about BP, right? So that's very important. Next is, how do we assess refractoriness? You say, okay, fine, I get the BP map 65, I look at diastolic pressure, I look at arterial tone and everything, great. Then what is next? How do I know the patient is getting better? This is extremely important because this is what refractoriness is all about. What is your response? So like I told you before, these are your markers that you look at. So lactate is simple, right? It's a point of care test, it's cheap, it's readily available, but it has its problems. Because we know from Cohen-Wood's classification, if you have ischemic liver injury, the clearance is going to be slow, right? If you've given adrenaline, right, it's going to be type B lactic acidosis because of increased pyruvate production. So there are many problems with lactate, but lactate is fantastic at the initial stage when a patient comes in with cardiogenic shock, because with lactate it's high, their mortality is high, they are higher stage of sky staging. So it is useful, but tracking it sometimes may not be so useful. So you know that limitation that it has. When does lactate rise? Textbooks will tell you that it rises when the DO2 to VO2 ratio starts to fall critically at 2. But we know that the body is heterogeneous. It favors certain organs opposed to others. So we have seen before, blood pressure is normal, but the patient's liver function still goes haywire. The reason for that is because the liver is not favored, the brain, the heart is favored. Right? So in the critically ill patients, the curve looks like this. So the lactate rises not when it's 2:1, but a lot earlier. So important to understand the weaknesses, but lactate is a useful biomarker in the initial phase to look at perfusion. Right, so I won't belabor the point here, but the Cohen-Wood's classification gives you an idea of all the different possibilities when it comes to lactic acidosis. Now, CO2 gap. So CO2 gap is something that I use a lot for global perfusion. What is it, basically? I have a right IJ central line, right? So we tend to favor putting in the right IJ. It's cleaner, right, and it gives you a lot of data. And of course, we almost always will have an arterial line in the ICU, right? So if you look at the difference between the arterial and venous carbon dioxide levels, the normal value is less than 6. But again, the absolute number is not very useful, but it's the trend that's very useful. Because if I'm meeting the DO2 and VO2 are matching, right, I expect the CO2 gap to come down. Now, people ask me, so why does the venous CO2 go up? I mean, O2 goes in, CO2 comes out, right? So why is there an increase on one side? The reason is because when you have anaerobic metabolism, you produce acid. That H plus needs to be bound to bicarb, and that bicarb then forms carbonic acid, which then dissociates into carbon dioxide. And that's the reason for it. So the moment I say this, a very sharp person will say, hey, but what if I intubate the patient and I ventilate them, I drop the arterial CO2, I automatically kind of widen the gap, right? It's true. But like I said, one value is not useful, right? In fact, I see the opposite quite often, because when you have a patient in respiratory distress, up to 25% of their cardiac output goes to just maintaining breathing, right? Under normal physiology, it's less than 5%. So you intubate that patient, you actually reduce the VO2 demand that the respiratory muscles put in. And even though you may see an initial rise in the CO2 gap, later on it starts to come down. So we track that and we trend that to make sure that the global perfusion is still intact. SCVO2 or SVO2 you can also use, right? So you can imagine if the blood transitions, it takes a long time. Everything keeps extracting. What's back is going to be much lower. And the factors that affect the SCVO2, again, is going to be your HB, your CO, SaO2, VO2. So some of my colleagues ask me, hey, you're an ECMO patient, why do you paralyze the patient? It's because I've done everything, I can't do anything more. There's nothing more than ECMO. right? All I can do now, HB I've corrected, CO I've done what I can, SCO2 I've done what I can. All I can now intervene on is the VO2. So I paralyze the guy, I sedate the guy, turn off his brain so that I can reach the point where the patient can survive. So this is very important. So these are elements that you can track. Now, echo is extremely important. I consider it as part of the physical examination. Every single patient in the ICU gets an echo during rounds. The echo is my medical officer. It follows us everywhere we go. But echo has its flaws. Echo is angle dependent. Sick patients is hard to do. It's very difficult to reproduce. You must remember the weakest member of your team is usually the member that sees the patient the most. Right? So if you use echo and your cosine theta is all over the place, it's not going to be actionable. So echo is useful to look for things, to look at EF, to track things, but be very careful if you're using things like BTI or cardiac output calculations. So PA catheter. So PA catheter, everybody knows it's useful, right? The jury is still out for some people, but we know it's useful when it's done properly, right? And there are many things it can use to guide. But what I will tell you is that PA catheter, when you insert it, is very important. I told you 30 to 50. I got more shock patients than that, but only insert it for 30 to 50 patients a year. Why? It's because PA catheter, we use it only when we know it's going to be useful, right? So the guy is alert, peeing urine, he looks happy, all the numbers look bad. I know he will get better. I will wait. I won't go and jump in and say, okay, I'm going to put a PA catheter for you, because everything looks in the right direction, right? But the patients where I don't know, I do it, but I do it early. So I have seen people put it in third day. Because they say, hey, I started knowing everything, but everything seems stuck, the organ's still getting worse, I put in the PA catheter. It's pointless, right? It's using a parachute after you hit the floor. Right? I always tell the residents, you want to prevent multi-organ failure, not diagnose multi-organ failure on the PA catheter, right? So I won't belabor this one because I think the next speaker will be speaking about it, but PA catheter gives you a lot of values, right? It tells you how bad is the congestion. It also helps you track your cardiac output. And if you're going to use a mechanical circulatory device, it tells you which is the appropriate one. Right? How are you going to tell your hospital administrator, oh, I decided to put an impeller, but oh crap, RV was bad, so I switched to ECMO. He will look at you and say, what are you doing, right? So you have to use it to adjudicate mechanical circulatory devices as well. So what is successful? Successful is when you see improving trends, not a specific value, but improving trends. So a patient who never had heart failure before has MI, a cardiac index of less than 2.2 is terrible. But how many advanced heart failure patients you have seen walking around, cardiac index is 1.8, 1.7 at the baseline, right? So if you use, for example, Detroit shock protocol, 2.2 below is cardiogenic shock already. So how? Next, congestion. So I know it may be a bit out of time. Congestion is extremely important, and a lot of people in the ICU tend to follow the early versus late dialysis data. But you must understand the physiology is very different. If you have a septic shock, if let's say I put a cannula and I put endotoxin in me, my cardiac output will go up, right? Because what happens is my vascular tone is the one that falls, right? When the heart ejects, it's all wasted energy, right? Nothing goes into the system, and there's a lot of shunting that occurs. So the mechanism of AKI is very different in a patient in a medical ICU as opposed to a patient with cardiogenic shock, where there's no blood flow to the kidney is a filter, right? No blood flow, the input is low, but the back pressure, which is the CVP, is extremely high. So again, then you say, oh, so everybody I need to dialyze? No. So what you do is you see what the urine output is. Now we know that how furosemide works. Furosemide binds to albumin, it gets to the kidney, decouples, and then it goes into the organic acid transporter. From organic acid transporter, it gets into the urine. From the urine, it travels to the thick ascending limb, and then it binds to the sodium potassium 2 chloride. We studied this in medical school. If there's no urine, how is it going to get to that channel? It can't. Right? So if there's no urine, don't bother with Lasix. If you have some urine, you can give Lasix. You know the peak onset of action is 2 hours. In the next 2 hours with the indwelling catheter, you should be able to tell whether the urine output will pick up. If it doesn't pick up, patient is in very bad APO, I think you should start dialysis earlier. So that's what we tend to do. And we have lesser rates of prolonged AKI, prolonged dialysis when we do this. So data shows that, even compared to cardiac output, your CVP is a bigger marker of AKI, right? So you can see the cardiac index here, 1.4, but you can see here CVP 24, much bigger impact on worsening kidney function. And it's also seen in the ESCAPE trial, right? When your wedge pressures are very high, mortality is higher. So you have to treat congestion with a lot of respect. And the more contemporaneous data also shows the same thing, right? Whether it's AMI CS, whether it's heart failure CS, once you have congestion there and you don't treat it, mortality goes up. So decongest early, and always don't wait too long. Don't give Lasix, and the urine output is 10 for 10 hours. It doesn't make sense. Early versus late intubation. Now, I've alluded a little bit to this. When the patient is in distress, you intubate them early. You don't want it to do it late. Now, there are a lot of interventional cardiologists in this group, right? And I can tell you they hate it when the patient is APO sitting up while they're trying to do PCI. And then someone has to do violence to the patient, try and intubate the patient. It's very difficult. So what you want to do is you want to get the patient calm, you want to reduce the VO2 requirements, so you intubate early. Now, anesthesiologists will be very good people to speak to. How to intubate an acidotic patient. What you set the ventilator beforehand. What is going to be your tidal volume in the initial? What is going to be your respiratory rate, right? Using cardiostable drugs, ketamine, etomidate. These things are very, very useful. But there are caveats. And later on, when I talk about RV failure, I'll talk about caveats. RV function, RV failure is a big problem when you're intubating these patients. So what is the most important ingredient of all? So everything I told you are simple, right? You don't need to be a resource rich or resource poor. But the most important ingredient is time. If you respond 24 hours too late, 9 hours too late, patient will die, regardless of what you do. Whether it's ECMO, impeller, it doesn't matter. It will have zero impact. So that's why we go by shock teams and MCS workflows, so that we get to these patients early, right? And so I showed this previously. So we have a protocol where we know what is the inclusion-exclusion criteria, when are the junctions in which we will discuss and we will put in we will put in MCS devices. So in summary, response time is important, right? So shock team has to be there. Treat the underlying cause, right? Don't try and play around with things. So putting a central line instead of doing PCI, for example, doesn't make sense. Just get a peripheral NOA in, move the patient, start the treatment. Consider intubating early when appropriate, right? Of course, get the more senior person to do it. When the patient comes back, don't flip a coin. Assess perfusion, tailor the therapy to that patient, right? And escalate when it doesn't go in the right direction. That's when you need to start thinking about MCS devices. Generally, the rule of thumb is you need to have a decision by 6 hours. Yeah, so that's what I go by. And with that, I will end. Thank you.
Thank you, Dr. Kamlesh. That was an excellent and elaborate, very precise talk. Thank you so much. My question to you is, when do you said decide on MCS upfront, that is definitely. So do we decide on MCS before the PCI, if it's a primary PCI with cardiogenic shock, in the ER room, in the cath lab, where exactly should we take the decision? And what parameters will decide whether you go on a IABP, which is widely available, ECMO, which is also reasonably available. Impella is much more expensive here. So when should you talk about Impella? When should you talk about ECMO? When do you use a combination? Can you just brief on it?
So perfect question, and I don't know whether I have the best answer for it, but what I will tell you is that it is very difficult for one person to make a decision at a certain time point. So for example, if let's say you have a procedure where ECMO is inserted by a surgeon, right? You call the surgeon is not there. He has to listen to what you say, and he has to make a decision whether ECMO needs to go in, right? Whether you have done enough treatment to try and reverse the pathology, he will just have to believe that you have done that, right? It's very difficult to tell. So what we do is that we pull everybody inside. Even before they need ECMO or need any kind of MCS, we pull all the stakeholders will decide early. So if let's say the patient is in the A&E, they need to get to the cath lab. They cannot move because the blood pressure is on the floor and they have started norepinephrine, the drug doses are going up. So you see the sky stage is E, right? I can't move the patient, but I cannot just say, okay, I'm going to wait for 8 hours. You can't do that. So those patients, the ECMO team will go down and ECMO will go in because you can't put impeller in the A&E, right? So quite straightforward. Now, let's say the patient stabilizes in terms of MAP, that's all they can do. They transfer the patient to the cath lab. Now, at the cath lab, if let's say while you're doing your interventions, you realize that the blood pressure is starting to fall, your vasoactives are going up, again, very simple. The decision is made for you. You have to put in the ECMO. If you have data to show the RV function is good, whether it's echo or whether it's PA catheter, you can of course try impeller, right? And we have the same problem. Impeller is very, very expensive. So to put it in, you need to adjudicate with a PA catheter. So if it's declared, it's declared. But if let's say it is not, this is the part where it's very tricky, and I actually kind of disagree with the Western system where you put in the PA catheter, cardiac index less than 2.2, right? Impeller goes in, ECMO goes in. Because when we look at our own data, there are so many of these patients who had very bad looking numbers, 1.2, 1.3, who never required MCS, except maybe IVP. Because IVP is cheap, it's easy to do, everybody's comfortable doing it. Almost all of them will have IVP. But majority didn't need ECMO. So if we follow the Detroit shock protocol, like I said, everybody gets ECMO. So what we do is that we reassess. Say, look, 2 vasopressors there, MAP target has been met, you have done your PCI, you put in the IEP. What we do is we keep a sheath in to railroad for ECMO. So IBP immediately becomes a venting strategy automatically for if ECMO is required, because that is mandatory for us. We don't want a situation where you put the ECMO in and after that come in and put the IBP in. IBP will be in there to vent the ECMO. All ECMOs we vent them. So it makes it easy. Then we have the access. The surgeon doesn't have to struggle to insert it in the very vasoconstricted patient. They will just have to railroad, very easy. And the interventionist will insert it in the right angle. Right? A junior doctor, for example, they will put it very steep angle, the cannula is very big and it's a problem. So plan B is already settled when the patient moves to the CCU. Once they are in the CICU, then what we do is that we look for effectiveness. Is the patient getting better? If the patient is getting better, fine. If the patient is getting worse, what are you going to do? Do you have anything from the data that you have that you can do? If you have nothing, MCS goes in. If you have something, then you try that and you track again. Within 6 hours, you must make a decision. So that's how we manage it. Very difficult for one person. And it's very stressful also.
Absolutely.
Yeah.
That's a very, very practical solution in low resource or medium resource settings. I think that's an excellent way to handle it. Thank you.
Thank you, sir, for the great insights. Just one question. Among the pulmonary, during right heart catheterization, I feel pulmonary artery pulsatility index is the single most important decision-making factor. But according to your vast experience, which would you consider, sir? Whether PAPI is the best index, or we need to take into account all the parameters in an emergency situation?
Yeah, so it is challenging because most of the data shows that PAPI is the best, but PAPI only looks at pressure, it doesn't look at flow. So it is a little bit challenging. But what I will say is that we don't try to use one parameter, we use echo as well. Echo, it may seem like it may not be the best parameter, but actually it does help you, right? Because if the RV looks really good on the echo, generally speaking, the PAPI will be okay as well, right? Number 2 is that, is it chronic heart failure or is it acute heart failure? Again, the cutoffs for the PAPI also varies. And if you do the math, you will know why it varies quite dramatically. So I would say PAPI, yes, it is useful, but we always use multimodal assessment. And why PAPI is so useful is because heart is a pulsatile system. So pulsatile system that is good, you have high systolic, basically your pulse pressure is wide. If your heart is good, you will also clear the blood better, so your RA pressure is low. So that is the concept of it. But the patient is also very congested at that time. So you can see the PAPI varying very dramatically. So although literature says that it's very good, but when you track it in the ICU, you realize that actually it goes quite up and down quite a bit. So I would say that yes, at the initial stage in the cath lab, you have nothing better you can use. But later on, actually, I use echo, I use PAPI, I use everything, RA pressure and all the parameters. But to me, the most important is not those parameters, but it's the flow targeted resuscitation. Lactate coming down, urine going up, CO2 coming down, I don't care what the number says. I really don't care. Yeah.
Thank you so much. May I invite our next speaker, Dr. Veena Ramanan, to give the lecture on bedside hemodynamics, a very important topic in acute heart failure and cardiogenic shock. The stage is yours.
the outset, I would like to thank the entire Billroth team for giving me an opportunity to present over here. It was a wonderful event from afternoon. So we are all coming towards the end of the session. I also am very honored to present this small topic which is very important. It's in front of the esteemed moderators here. And lastly, though me and Dr. Kamlesh have not met before, most of our slides are overlapping. So, so I will just skip those slides, and it only says that they are all very important. That is, I think there are a few studies which were landmarks in management of cardiogenic shock. There are few slides which are indispensable for management. So with that, let me start this small practical session. It is very practical how bedside hemodynamics are going to be useful in heart failure and cardiogenic shock. We are talking about AI, we are talking about so many modern monitors, but the bedside in assessment is indispensable. I hope the younger generation don't lose that valuable asset. So I don't think any AI can replace a hand on the pulse. How is the patient? How interacting with the patient? So with that small note, let me begin my talk. So cardiogenic shock journey is termed in most of the studies as ROSE. So ROSE, the abbreviation is you have to recognize first, then you have to begin the rescue therapy, then comes optimization, stabilization, and then finally most important is de-escalation or the exit strategy. So all these things has to be planned when we are meeting a patient with cardiogenic shock. This has to be our mind map when we deal with a cardiogenic shock. So this is the famous, I'm not going to deal with the SEAI grading of shock. Why I have put this slide is, it is important to stage the patient. We need to know what stage of the patient he is when he is presenting to us. So how is he going to progress in that trajectory? Whether he is going to ascend up, whether he is going to descend up. So this study which was illustrated by Dr. Kamlesh, it is by, if it is possible, I think I would recommend this to all the audience present. So here, what is interesting about this study is they have, the SEAI guidelines has been there, staging of shock has been there from time immemorial, and it is incorporated in the heart failure guidelines. So what these people did differently is, how there are so many different variations, how you stage this patient as stage B, how are you going to tell that he is deteriorating. So they formulated few things to categorize these patients with ease into each stage. So mainly they have focused on hypotension, any form of hypoperfusion, and most importantly they have included the treatment intensity. So they have included inotropes, they have included mechanical circulatory support, and that takes part in staging. So that is very interesting about this study, how they have incorporated into the ACAI guidelines. I'm not going to go into more details about that. So again the phenotyping which was discussed. So why, once we have staged, then why do phenotyping? Why is it important? We know that A, B, C, or I think all of us in the audience will be knowing this famous hemodynamics profiling of cardiogenic shock. So it basically not only facilitates risk stratification, but most importantly, it tailors patient-specific management. So the staging does not tell you how are you going to manage it for each patient. There will be 100 patients in stage D, but each 100 patients are going to present to us differently. So that phenotyping has to be kept in our mind, and we'll have to do it bedside. It is not, you don't need monitors, you don't need invasive monitoring to do this phenotyping. And that goes a long way for initial assessment of shock. So this Forrester classification originally it was published in 1977. So after that there are many variations of that, and it is incorporated into our heart failure guidelines. So what is important in this guidelines is, again, the same classification, they have incorporated bedside maneuvers to determine low perfusion and bedside indicators to determine congestion. So that is how we categorize in the bedside. When the patient comes to the ER, immediately we can hemodynamically profile them if we follow basic bedside assessment. First, we need to keep it in mind, how are we going to see whether the patient is perfused or not perfused, whether he is warm or cold, and next, whether he is congested or not congested. The moment we know these two things, we can easily profile them, whether it is dry and warm profile, wet and warm profile, wet and cold, or dry and cold. So the reason why we profile is, first thing is, the initial profile itself determines mortality. So they have told that wet and cold profile have almost 50% mortality. But what is more important is the rapid progression among these profiles. So when they come with a low mortality profile, and if they are progressing to a higher mortality profile, I think the mortality what is reported in the studies doubles. So that is what is important about phenotyping of these patients. So with that note, now coming to the details of, now we are talking about non-invasive. So when do we go for invasive? Whether non-invasive itself is not enough, whether we need to put PA catheter. So PA catheter has gone into disuse because of many large scale studies which was done, which has proved that it is not so beneficial. But when you look at the profile of heart failure patients, there is no doubt that PA catheter is invaluable in managing heart failure patients, not only in managing heart failure patients, in escalating them, whether they require MCS or whether they, to assess whether they are a candidate for any other escalation for destination therapy, for heart transplant, for LVAD. So many things, PA catheter is invaluable. But that doesn't mean that any patient comes to ER, we are going to put them on PA catheter. So there are broad indications. Among them, the most important thing is, when you are titrating the vasoactive drugs in cardiogenic shock, especially if it's a difficult cardiogenic shock, you have 4 or 5 drugs, but what drugs are going to choose and whether that drugs are really helping. So PA catheter helps in that. When you have a pulmonary vascular disease, and then when you are not able to profile this patient when he is at admission, whether you are confused, whether he is dry, because there are a portion of patients who are cold and dry who are hypovolemic. So these are the patients who are missed in our common diagnosis. So these patients require different treatment. We don't have to give them inotropes. There are so many things. So these are the profile of patients who are going to benefit with pulmonary artery catheter. Next thing is, like I told, optimization of therapy, especially if you're going to escalate them to mechanical circulatory support or a transplant pathway. Initial assessment, right heart catheterization is a must. So with that, what are the important, there are, PA catheter gives, if you list, there is an endless list of derived variables which PA catheter is going to help us with. But the most common practical parameters which we are going to use for shock, I am not going to go into the details of what is used for right heart catheterization for transplant candidacy. That's an altogether a different scope of topic. So what is used for categorization is, we tell, that is very famously called as RA to PCWP ratio. The reason we do this is, it immediately, if you're going to use, once you put the PA catheter and you know the CVP and you know the PCWP, once you know the ratio, you can immediately classify them, whether it is a congestion because of left-sided congestion, whether it is a right ventricle, whether right ventricle is contributing to the congestion, or this patient has a biventricular disease, or this patient is a hypovolemic patient. So this immediately gives us a direction, path where we should go, because the treatment for a right ventricular disease is completely different for the treatment from the left ventricular dysfunction. So the identification of that is very important to proceed. Next important prognosticating factor is cardiac power output. So if we have the facility of putting a PA catheter at the beginning, for any patient, if there is an indication, cardiac power output, there are a lot of cutoffs for that. Normally, critically, it is less than 0.6 is the cutoff. What it says is, it's a strong, many studies have proved that it is the strongest independent predictor of mortality. That is the initial cardiac power output. It is not after optimization. If we are having a chance to put at the presentation, the low cardiac output at presentation is the strongest independent predictor of mortality. And the trend. Next thing is how else it can be used is the trending of improvement. It just gives you the direction that you are going in a right way. The next again, like Madam asked, it's about PAPI. So it's a very fancy measurement. Of course it is useful. It measures like, it is mostly a right-sided measurement. So what it does is, it measures, like Dr. Kamlesh told, it measures the pulsatile performance of the RV relative to the preload. Whether to that preload, if the CVP, even if the CVP is 20, for example, if the RV is able to push that out into the pulmonary vascular system, it's a simple thing. If the RV is able to generate that force, that means that that RV is good. So that is what exactly the pulmonary artery pulsatility index measures. So it is only the ability of the RV relative to the preload. It's not that in CVP 40, it's just with relative to the preload, whether it is able to generate that tidal volume, forward flow. So another surrogate of this, it's not a surrogate for this, it's a hydraulic energy, it's a right ventricular stroke work index. So what does this imply is, how much mechanical work this RV can do to push this blood into the pulmonary artery. What is the work the RV is doing? Is it struggling or is it doing it with ease? That is what is, in short, it's simple terms, the RV stroke work index. So both these measurements, PAPI and RV stroke work index, give you a clue what is the status of his RV. And that gives you a clue what direction you need to go. Whether this patient, see, any patient, any left heart patient or anything, when RV is compromised, even in MI, even in heart failure, when your RV is compromised, your mortality, your prognosis, everything steepens. So it worsens. So assessing the RV is very, very important. So apart from this, there are many parameters. I'm not going into the details, transpulmonary gradient, diastolic transpulmonary gradient, SVR, PVR, so many things are there. But for categorization of shock, if we are able to get these values first, that is enough. Most importantly, what the pulmonary artery catheter does is it gives you the mixed venous saturation. So that is the most predictor of a low cardiac output. And it also can be used as a trend. The patient comes with 40% venous saturation, you are giving a therapy and it is improving. That itself is a trend. So there are PA catheters which show continuous SVO2. So they are all the upcoming PA catheters which give you a trend. You don't have to keep taking PA saturation. You have to just calibrate it every 8th hour or 12th hour or a day, once in a day, and it gives you a trend. And it can tell you in between breaks, yeah, your therapy is not going well, or this is a time to escalate. So these are the things where invasive monitors, PA catheter comes into play. Now coming to bedside analysis, like how Dr. Kamlesh had told, whenever you are doing a bedside assessment, this whole topic is only bedside analysis or assessment for cardiogenic shock. We need to always keep two things in mind. First, you have to see signs of perfusion. Parallelly, you have to see signs of congestion. That is all. You have to see whether the patient is perfusing, patient is congesting, or whether it is both. So first thing, keep the hand on the patient. When you are going to examine the patient, whether the patient is cold, whether the pulses are thready, whether the capillary refill time is prolonged, whether there is skin mottling, new altered mental state. Patient comes, he was okay, and he's suddenly become irritable, restless, he's not oriented, and recent oliguria. And lastly, I have put, because it was emphasized in detail by Dr. Kamlesh, BP. BP is not put as a first. So BP is put in the last. But more important than BP is the pulse pressure, because the area under the curve gives the stroke volume. And stroke volume is what is important. So if the patient presents with a narrow pulse pressure with all these, it immediately says that yes, this patient is not perfusing well, he is in a low cardiac output. Having done that, next is we are going to assess whether this patient is congested, whether there is congestive symptoms. So Krebs, pedal edema, ascites, raised GVP, very important, congested palpable liver. So these are the bedside maneuvers. So by just doing these things, we can profile the patient, we can stage the patient, we can know what direction to go and how are we going to start our therapy. Last but not the least, it should be written first, but just to emphasize is history. We have to take a detailed history of the patient. Different profiles, like I told, stage C of heart failure can have 100 presentations. So the history gives us a clue where we are heading to. It can even give you the diagnosis. You don't even have to examine the patient many times. So we should not underscore the importance of a good history taking. Next, to aid that, what point of care under that, this one, in the bedside, what can we do? So we can take a venous or arterial ABG. What will it show? First thing is lactate, whether the lactates are high. So overall, if you look at the studies, poor lactate clearance is one of the, again, independent risk of signs of mortality. High lactate at presentation, poor lactate clearance is again one of the predictors of mortality. Then invaluable is your venous saturation. What venous saturation the patient is coming in, whether he is really having a low cardiac output. Patient can have only congestive symptoms. He can be a warm patient. So all these things already you have done, but you are confirming with your bedside ABG. Then again, low PCO2. Like it was told in one of the talks, low PCO2 in a patient who is coming normally, and low PCO2 is an independent predictor of low perfusion. Because he is not able to perfuse well, PCO2 is low. Acidosis, and then invaluable, again it's put in the last because it has to be, bedside echo is invaluable. So any patient coming to this one, once we are done with the rapid analysis and we know what profiles, we have to confirm this profile with our bedside echo. So the bedside echo tells many things, whether the patient is having biventricular dysfunction, univentricular dysfunction, IVC is congested, whether there is any effusion, or whether it is a non-cardiac cause of shock. We don't know what is it. We are assuming that this is a thing. So these are the things which the simple bedside echo, you don't need a trained echocardiographer. We all can do simple bedside echo. So with that, next thing is, if we are progressing to the next, simple bedside blood tests which we can do is, one is the NT-proBNP. Though it individually it does not have a value, it does not have a significance, it gives you a trend. So if the patient has, if a heart failure patient has come to you with decompensation and his NT-proBNP value has raised, that means that he is going up on the trajectory. So you need to intervene and you need to up your therapy, whether it is from medical therapy to MCS or from MCS to some other thing. So it will give you a trend. This is not an isolated monitor. I am telling it is clubbed with your all other things. Then how is your other end organs, whether it is single organ or whether because of this single organ other organs are getting affected. So with this small background, I am just going to run through few scenarios. These are all real-time scenarios which we encounter in our heart failure clinic, in our heart failure institute. Every day, patients who are listed for transplant or who are listed in the heart failure clinic, most of them they present with this, and surprisingly none of them require high-end invasive monitors to come to a diagnosis what we should do for these patients. So let's go to each one of it. So this is one of the examples. Known heart failure patient listed for transplant comes to the ER in the night. He is breathless, he is very neurologically dull, he has low urine output last 1 day. So this is the BP. BP is 100/70. So pulse pressure is around 30. And pulses are felt, but there are bilateral crypts, pedal edema is present. Echo shows severe LV dysfunction. He is already listed for heart transplant, but IVC is congested with severe RV dysfunction. And VBG shows lactate of 4 and venous saturation of 42%. So when you look at this patient, we have already done the preliminary examination. Pulses are felt, he is having crypts, that means that he is congested. So he is a warm and he is at present, though it is biventricular dysfunction, but that is not the problem at present. His congestion, oliguria, congestion is a primary problem. So though he is in SACIB, he is warm and wet. So the treatment would be just IV diuretics, CPAP, and some dilators. So whenever a patient presents, every patient need not have every heart failure patient need not be treated with a inotrope at beginning. So this is a small example, very simple case to just tell that this patient is congested. He has skipped some dose of diuretics, or we have not given enough of diuretics for him, and he is decompensating. That is all. So this is a simple bedside diagnosis. Then these are two scenarios which can come, contrasting scenarios though, with similar complaints. So patient is again listed for transplant, is coming to the ER. He is coming with severe abdominal pain this time, epigastric pain, retching, poor intake of food, low urine last 2 days. On examination, so he has low urine. On examination he has bilateral crypts. Again pulses are felt, but his JVP is high. We are able to see visible pulsations. We are not measuring JVP, we are able to see visible pulsations. He is having bilateral pitting pedal edema. But striking thing is he is having hepatomegaly, and very painful hepatomegaly. The moment you are touching the liver, he is wincing with pain. Lactates are 4, saturation is around 45. There is one more patient coming. He is also coming to the ER with severe abdominal pain. This patient is also listed for transplant. He was on ambulatory milrinone. When we take the history, he is telling that he was on ambulatory milrinone. That is, he was on a home inotropic therapy. So this ambulatory milrinone has a half-life. Like we give it in the epidural pump, which runs for around 72 hours. And every time they have to refill this pump. That's how we send the patients to home here. So this epidural pump has stopped for some time, and he is thinking that, okay, next day morning I'll come and fill it. So that is how milrinone has not gone for few hours. And now in the middle of the night he has vomiting. When milrinone has stopped, he is not passed urine. And he is very irritable. Pulses are thready. Peripheries are cold. Severe pain in the liver, but liver is not enlarged. But pain is there. So what do we do for these two scenarios? So when you look at, so next is our echo. When you look at the patient with profile 1, that is when the patient who is having pedal edema, who is having crypts, pulses are felt, hepatomegaly, is having this kind of a picture. His IVC is congested, and RV dysfunction is there. Of course, there is LV dysfunction, that is why they are listed. And this is the patient who is coming second. So he is having if you can see, he is having a severe contrast in the LV. His RV function is excellent. So his IVC is not a problem. When you looked at the IVC, it was around 18 to 20. It was some collapsibility was there. And that's how the heart failure patients were. So when you look at these two patients, there is a striking contrast in both the patients. So first patient presented with congestion. It was mostly a right-sided problem. And the second patient was, because his milrinone had stopped, he's milrinone dependent, this LV definitely requires milrinone, and is presented with low cardiac output. It's a left-sided issue. So when you look at these both patients, so first of all, heart failure patients coming with abdominal pain, we have to have a high index of suspicion. So it will not be a primary abdominal issue. And abdominal pain can be because of congestion, can be because of low cardiac output, and which have two different treatments. Of course, starting inotrope on a congested patient is not going to harm the patient, but congestion is diuresis is what the patient needs. He needs to be nicely negative for his hepatomegaly to come down. On the other hand, if you're going to give diuretics for the second patient, it might help. But unless you are going to improve his heart, you're going to restart milrinone, or you're going to up his inotrope requirement, he's not going to improve. So this is what the bedside does. We have not used any fancy monitors here. It's only just simple bedside analysis. So the next scenario is a patient who is a coronary artery disease. Till now we were dealing with dilated cardiomyopathies. This is ischemic cardiomyopathy. Coronary artery disease, burnt out LV, diffuse lesions. He is not fit for any vascularization. So his EF is only 15%. So there was no other way, he has to be listed for transplant. And he has come with drowsiness, low urine output, poor intake, severe body pain. And when you look at it, pulses are again thready, BP is low. For an ischemic cardiomyopathy, your BP thresholds are very high. That is to tell that it is low. Even 100 BP, for an heart failure patient, generally we accept lower BP. But in an ischemic, they don't usually tolerate hypotension. They have a lower threshold to tolerate hypotension. So what do we do for this patient? So when you notice any patient with ischemic cardiomyopathy, in a history ischemic cardiomyopathy, escalation should be very rapid. So this patient had lactates 3, acidosis. So he was started with inotropes, a short trial of inotropes were given. And this is his echo. It showed good RV function, severe LV dysfunction. IVC was 2 centimeters. And what was tried is diuretics and inotropes. But unfortunately, this patient didn't do well with this, and he didn't tolerate inotropes, or he went in for tachycardia, BP, which is very common in ischemic cardiomyopathy patients. What we need to understand is the milrinone therapy which we give for dilated cardiomyopathy patients do not work for them. By and large, the coronary perfusion depends on some amount of systolic pressure. They don't tolerate this. So we don't have that option. There are some patients, fully burnt out LV, they will benefit. But by and large, they don't benefit. So for these patients, early initiation of TCS is a best way to keep them okay till they undergo transplant. So we put IABP for this patient. He was okay till POD3. On IABP, again his pulses are thready, low urine, inotropes were on with IABP. This is when we thought we have to escalate this patient to a higher therapy. We put a PA catheter. PA catheter cardiac index is 1.5. His wedge is 29, CVP is 18, PAPI is low, and X-ray is showing congestion. So with these parameters integrated with our case profile, it shows a biventricular disease now. So there is an X-ray congestion, PAPI is low, CVP is high, wedge is high. So this is the patient who will not benefit only with IABP. And IABP has not worked. On IABP, he has deteriorated. So this is the patient who needs to be escalated to a VA ECMO as soon as possible. So this is a biventricular, just to assess what happens, this is a biventricular failure. He's already gone to Intermax 1 and we have to escalate to VA ECMO. Further moving on, once we establish, usually in ischemic or any heart failure, once we put VA ECMO, there is a temporary period of relief. Urine starts pouring down, patient becomes better, we can extubate the patient, he was doing well and he starts eating. He's waiting for transplant, but he's doing well. That's what happened here. He had immediate improvement. He was pouring urine. Slightly upon lactates, we expect lactate clearance to take a little longer time to take. But after 2 days, suddenly he was awake, he's eating food. He developed pink frothy sputum. He developed increasing breathlessness, requiring NIV. Slowly he started. We had to ventilate him. So what happened here? So when you look at it, this is what was his echo finding. So suddenly his LV has got distended because we have put a patient on a VA ECMO, his already heart is failing, and this is what happened. This was his X-ray which was very good. He was extubated. X-ray was good. And when you look at the monitors here, you can see that there is no pulsatility in arterial flow. That is, he is completely ECMO dependent now. ECMO flows are only maintaining him. And when you look at the wedge, which is shown in the yellow, this one here, it is showing 27. When a patient is completely on a VA ECMO, wedge should not be high unless LV is distended. So what do we do for this? So this patient was vented with LV vent, like how it was told, all patients, some institutions follow that venting at the initiation of VA ECMO, some institutions do when it is necessary. So this was the patient who was vented. Then LV venting was done post-operative day 8 or 9. Patient became better in the sense that lactate became 1.9, CVP became 10. Strikingly, wedge reduced, urine output again started resuming, and his X-ray became better, PF ratio is good. And this was the patient who will now, we will not be able to remove ECMO for him, though his RV only has improved. His LV is not improved because he is listed for transplant. He has severe left ventricular dysfunction. So this is the patient who can be de-escalated. So that is what your hemodynamics help for escalation, and it helps for de-escalation. So since this patient was on ECMO with an LV vent, what we have done is removed the ECMO with the oxygenator and kept only LV vent and axillary inflow. So this is a form of a temporary LVAD. So this is a bridging therapy for the transplant. So when we start off with managing a cardiogenic shock, we have to, that's what that Rice, for first slide, what was it? We should know what is the strategy, exit strategy whether we can de-escalate these patients and how our parameters are going to help us de-escalate this. So this is again one of the
Madam,
last
shall we
scenarios.
come to the conclusion, madam? Because can we come to conclusion fast?
Okay, sir. I'll skip all this, sir. So there are so many scenarios like that, but only thing is I want to say is classification systems provide just a framework, and objective bedside parameters guide management, and early physiological driven escalation preserves organ systems. Mechanism of shock determines which device to be selected and how to de-escalate and how to plan the destination therapy. Thank you.
Thank you, madam. Thank you. Wonderful lecture from the senior internist. Thank you, madam. For want of time, we go to the next lecture, sir. Management of RV failure and pulmonary embolism. What is new? By Dr. Kamlesh.
Okay, so in the interest of time, I think I'll probably skip the pulmonary embolism part because I think a lot of people have asked me questions on the RV failure management, how do we do it? It's not that we have all the answers. I think if you look at literature, it's very difficult to pinpoint a very good text that tells you how to manage RV failure. Now, to understand it, sure why the slide's not moving. So to understand this, I'm going to give you three very quick cases. The diagnosis is there. 36-year-old lady, 21 weeks pregnant, comes in with nausea, dizziness, low blood pressure, narrow pulse pressure, high heart rate. And when we look at the echo, it basically shows, clots, RV distension, clear-cut pulmonary embolism. Right? So how would you manage this patient's RV failure? Right? You will manage the PE, of course, but how would you manage the sequelae RV failure? Second case, 61-year-old female, known history of group 1 pulmonary hypertension from autoimmune disease, has fever, chills, and septic event, lactates elevated. Again, patient coming in with cardiogenic shock, right? Chest X-ray shows infection. These patients tend to be immunocompromised. Echo shows that the RV is big, right? Very different pathology. Third case, classic 61-year-old smoker, hyperlipidemia and diabetes, presenting with chest discomfort near syncope. When you look at the ECG, basically shows inferior MI with RV infarction, and the RCA is infarcted, and you see that the RV is a little bit dilated down. Again, very different pathology, presenting with cardiogenic shock, RV failure. How would this patient be managed differently? So in each of these cases, this is what people do. They will say, look, fluid loading helps RV. RV accommodates volume very well. I'll give fluid, cardiac output will go up. Some people will say, look, most important thing in shock guidelines is you start NOR-A, get the blood pressure up. So they target the MAP of 65. Some people say, look, cardiogenic shock, I need to increase inotropy, reduce vasodilatation. In fact, PVR can come down if I start milrinone. So some people say start milrinone. Some prefer dovitamin. Some people will do both, but they will use PA catheter to guide it. When the question is, all patients need PA catheter with RV failure, is that because guidelines seem to say that PA catheters are very useful for RV failure, right? And when would you start pulmonary vasodilator, right? Would you try systemic? Would you start pulmonary? So these are questions that people have. So what is important to understand is that RV failure presentation may not be as obvious as LV failure, right? So you have to have a high index of suspicion, and the echo again becomes extremely important. Now, the content that I want to cover, because we have a RV failure workflow that helps with the management and is guided by physiology. It's not guided by any guidelines or anything like that, but understanding the difference in physiology. So the first things I'm going to talk about is the ventricular physiology. Now, LV and RV ventricular physiology is extremely different. RV is much thinner, 6 times thinner than LV. Right? LV orientation of fibers, you have longitudinal fibers, radial fibers, circumferential fibers. RV generally tends to be longitudinal and is a lot of time related to the LV function. So RV cannot do very much, right? Because it's a very thin wall structure. There's only that much pressure it can generate. And its assessment is also very simplistic. So that's why you look at echo, we look at a lot of longitudinal parameters, which are very much loading condition dependent. So people like to measure things like TAPC, S prime, it's all mentioned in the literature, but I can tell you it's not useful. Because what is actionable is what is useful, right? If I measure a TAPC of 14 and then next thing I measure at 13, what are you going to do differently? That is important, right? It's not just making a measurement and saying, oh, the measurement is this. Now, pulmonary circulation and systemic circulation are extremely different. If you do not understand this, you realize that your management will be very hit and miss. Systemic circulation, the blood pressure is, like I mentioned before, very little resistance in the conductive blood vessels. Majority of it is at the organ level, the pre-arterioles and arterioles. Right? So pulmonary circulation is very different. The arterioles are not very muscular. The tunica media doesn't have much muscle. Even in the veins, you have pulsatile blood flow. And the other big difference, if I were to put any one of you on a treadmill and exercise, you realize that your blood pressure goes up quite significantly, right? Along with the cardiac output. Now, if you were able to measure the blood pressure on the right side, you realize that the pressure barely moves. The reason for that is because it's a very highly compliant system with many of the blood vessel channels not being utilized. So when your cardiac output goes up, the pressure doesn't go up because it just takes up more channels and it doesn't actually result in a very increased blood pressure. Right? So LV can manage high pressures, but RV cannot. Right? If you heard of the 60-60 sign in echo, what is that basically? It tells you that in an acute PE, right, the RV pressure cannot go above 60. In fact, most of the time it's 40. The reason is actually very simple. If right now you ask me to bench press 100 kilograms, I cannot do it. You can tell me, look, do the best effort you can move this 100 kilograms. I can't. No matter how strong my mind is, I can't move it. But if you give me 1 year, protein powder, daily date, go to gym, maybe I can do it after 1 year. So that's the difference, right? So pulmonary circulation, uninitiated to high pressure, very easily goes down. That's very important to understand. So systemic circulation, the control is at the organ level, right? The map may be by a baroreceptor, but what blood flow goes through that organ is determined at the organ level, right? So that is very important. So again, to summarize, pulmonary circulation, right, majority of the compliance is distributed. Systemic circulation, very different, right? Majority of it is in conducting blood vessels. If you look at resistance, pulmonary is distributed and there's a lot of unutilized channels that can be recruited, right? Dormant vessels, when your cardiac output goes up. So it doesn't have much load. Pulsatile afterload, what is pulsatile afterload? Pulsatile afterload is very easy to understand, right? When your artery distends, like Windcastle effect I showed you, it recoils, it sends a wave backwards. That's pulsatile blood flow. If it happens after the dicrotic notch, the aortic valve has already closed, it doesn't cause an increased afterload to the LV. But if you have very stiff vessels, let's say for example in elderly patients, renal patients, that pulse comes back much earlier, before even the aortic valve closes, and that's pulsatile afterload. So pulmonary circulation, higher of these pulsatile afterload, right? So if I were to show you this picture, it basically shows you, if you increase pressure, right? If you increase pressure on the RV, its function falls dramatically. The flow, stroke volume drops dramatically. LV can handle it. The reverse is true. LV is thicker, right? When I increase volume, it cannot expand. It's not as compliant. So the pressure shoots up inside the LV. So LA pressure goes up, patient gets pulmonary edema. RV, no problem. It can handle it very, very well. So pulsatile afterload, I've already explained, is basically Windcastle effect. It has an impact, particularly in things like pulmonary hypertension. So pulmonary hypertension, the compliance drops. This is a big problem. Pulsatile afterload goes up, static afterload also goes up. It's a very big difference from, let's say, RV infarction. Right? RV infarction, the RV fails. The PVR is not high. Very different physiology. So then people will say, okay, why don't I give pulmonary vasodilator? Why isn't a guideline showing that pulmonary vasodilators help? To understand that again, if you go back to physiology, you understand about time constants. Right? Time constants, a lot of times people study in the terms of ventilator. Right? When we talk about ARDS physiology, Pendeloo phenomenon, they talk about time constants, but it also is true in circulation. So if you reduce the resistance, the compliance gets worse. So the RC constant doesn't change as much. So you don't get as much bang for buck, right, when you adjust resistance. So that's why you realize that most people don't care so much about PVR. They care more initially about the volume, blood pressure and contractility. So time constant is a dilemma because you can't really, in the initial stage in cardiogenic shock, you can't really affect it very much. And if you try systemic vasodilatation, even worse, because your blood pressure crashes very, very quickly, right? So that's very important to understand. The next part of physiology, which I have to rush through a little bit, is to always understand the right side as well, right? The right side venous return is similar but not the same as the left side, the arterial side. Right? Your mean systemic filling pressure, your RA pressure, your venous return. So the Guyton curve basically. So this is a normal Frank-Starling curve or heart failure Frank-Starling curve is flattened. You basically, if you're on the steep part, you give volume, good, cardiac output goes up. If you're on the narrow part, you give volume, nothing happens, sometimes gets worse. Right? Volume matters. In the initial stage, let's say for example, if RV infarction, you give volume, the patient's end diastolic pressure doesn't go up very much. But if you have already excessive amount of volume and you already see that the LV is squashed, no longer polar ellipsoid shape, and is small, underfilled, struggling to pump, and you give more volume, the septum is going to shift even more. And that is a problem. So remember, giving volume versus take out volume is actually something you have to assess. And if you don't assess it, if you don't understand the physiology, everybody you give volume, some patients die, some patients survive. And that's because of difference in the original inciting pathology. So venous return curve is the other aspect, right? So if your RV is doing very well, RA pressure is low. If your RA pressure starts to rise, you realize the cardiac output starts to fall. So mean systemic filling pressure is actually very easy to understand, right? It's basically if you induce cardiac arrest, all of us have intrinsic pressure. So if you saw the movie George Clooney and Sandra Bullock in space, when the mask comes off, the person explodes, because we all have pressure, right? So that's very important to understand. So why is it important? Because the Guyton curve as well as your Frank-Starling curve, they interact. So if I have an impaired RV, you realize your CVP is going to be higher, right? So if I were to give, for example, if you look at the bottom on the right side, positive inotropic effect, you realize your CVP falls. Good. Cardiac output goes up, everything is nice. Negative inotropic, opposite direction. If you give volume, you see the one on top, you see you change the Guyton curve accordingly. So what you do will affect the eventual outcome on the RV function, right? So this is important. Normal, we expect, we give volume, I expect cardiac output to go up, right? But if the RA pressure is already very high, there may not be much increase in cardiac output. So where in the Frank-Starling curve you are? So septic shock, for example, you're vasodilated, stress volume is very low, right? You give volume to try and increase the stress volume, or you give no epinephrine, right? Cardiogenic shock, you realize the problem is the RA pressure is very high. So the delta is very small, right? So this concept is important. Next, ventilator. RV is one of those situations that I alluded to earlier where intubating is actually quite scary. Because when you intubate the patient, what happens, the intra-alveolar pressure will cause the intra-alveolar vessels to get compressed. But the extra-alveolar, actually, they tend to get better because they get expanded, they get pulled aside because of the anatomy. So, generally speaking, if you have very high pressure ventilation, you are going to have higher PVR. So in the initial patient, when the patient is struggling, you add an extra pressure on an RV you know is 6 times thinner than LV, they will collapse, right? They will collapse. So the impact of mechanical ventilation you have to understand. So a lot of times I use high flow nasal cannula, for example, to try and manage these patients. Next thing is, when you're going, if you have, sometimes you have to intubate, right? What can you do? You cannot say, oh, I cannot intubate, the patient is struggling, I cannot intubate. You can't say that. But you have to plan. So for me, I manage CBA instead of ABC. Because if I know the physiology, if I'm going to intubate, the West Zone 3 is going to become West Zone 2. Because we know West Zone 3, arterial pressure is higher than venous pressure is higher than alveolar pressure. West Zone 2, arterial pressure is higher than alveolar pressure, but that is higher than venous pressure. So when I intubate, I'm going to increase the alveolar pressure. I'm going to change West Zone 3 to West Zone 2. And you see what happens to your PVR. So if I have more West Zone 2, that curve changes, and I intubate the patient dies. So I will make sure if the volume should be loaded, I load them with volume, I start them on vasopressors early, then I try and intubate. That means I optimize the patient to reduce the risk of collapse during intubation. So this is very important. This one I won't go too much, but basically remember, the flow parameters are very important. Sometimes you don't have time to put PA catheters for some of these patients. Echo. TAPSE, TS prime, I've done it for 2 years, I find it's not very useful. You can measure, it's not reproducible, and it's usually not actionable. So what is useful is actually the septal shift. If the septum is, LV is very small, septum is shift, is squashed, you take out volume. Right? If it's D-shaped but LV is still functioning okay, right? Those are situations where you can give volume. So it's a very, very fine line. Right? So I've just mentioned this before. Now, some people talk about RV-PA coupling similar to the ventricular arterial coupling I mentioned earlier. You can measure these things with TAPSE and PASP. Again, is it actionable at the bedside? I don't know. Right? So we don't think it's very useful the more complicated things are. So PA catheter, again, I won't belabor the point, is very useful because it tells you the function of the RV and it allows you to track the impact of your interventions. Right? So this one again I will skip. So I talked so much about physiology, right? So tell me, so what do you do? What do you do actually in the ICU for the patient? So first and foremost, time. I will always belabor this point. Time is important, right? You cannot deal with it 6 hours later, 8 hours later. So you have to treat them early. Now, find out what the underlying cause is and treat the underlying cause. Because if you don't treat the underlying cause, then there's no point. Right? The patient is PE, you go and put in a PA catheter, measure the values, see how much volume to give. Instead of doing a thrombectomy, right? Or you get what I mean. You know, a patient is going to die. So you want to treat the underlying cause. Is it ARDS causing the problem? Is it RV infarction causing the problem? Is it PAH? Right? So if you read, again, you read the textbook, it doesn't give you much guidance. It tells you, is it acute on chronic, and it will tell you volume overload, pressure overload, it decreased contractility, impact. How are you going to make that assessment in the initial phase when a patient is very sick? So how I divide it is I look at the history, physical examination, ask myself, is this high PVR or is it low PVR? Because if it's low PVR, I know I can't do much for afterload management. I also know more often than not, volume helps. If it's high PVR, things like, for example, group 1 pulmonary hypertension, group 2 pulmonary hypertension, these are situations where I may not be able to give much volume. In fact, I may even have to pull volume. So this is why I like to conceptually divide it into these two things. So this is why I differentiate it, and this is just in words what I've just said. So I have a 3-step algorithm. It's very simple for the registrars and it's in order of importance. Preload is the most important, followed by blood pressure, followed by contractility, finally afterload. Why? Because preload is easy. Use echo, you look at the septal shape, look at the LV size, and you manage fluid removal or fluid administration with real-time pictures over time. And how do you remove the fluid? Again, I told you Lasix, you can try, it doesn't work, you can try CRT. CRT is good because you can control the amount. Is there a target CVP? No. Because remember, CVP is two things. It's cardiac output and preload. Right? So if you look at what Guyton says heart failure is the inability for the heart to meet the metabolic demands of the peripheral tissues, or only being able to do so with elevated filling pressure. So if I have heart failure, my filling pressure will be higher, my CVP will be higher. If my heart is normal, my will be normal. So if you put 500 fluid into my veins, my CVP is not going to go up because my Frank-Starling curve will shift, I will pump out more of the blood. So it is very important. CVP, you need something reasonable, but don't try to aim normal if let's say the patient's RV is bad. It may not be possible. Modes of fluid removal, I've talked about it. Okay, next, manage the blood pressure. Right? So they're already vasoconstricted, you manage it. So you can use norepinephrine, they say low doses doesn't affect PVR very much. Vasopressin also, low doses doesn't seem to affect PVR very much. So these help to maintain blood pressure. People try to give phenylephrine boluses. I don't think it helps. And I think it increases PVR as well. So it's not a very useful thing. We use it particularly for intubations. So I would rather start the vasopressin infusion or norepinephrine infusion before I even attempt the intubation. Right? And then only after you have BP control, then you give the inodilators. Because you don't want sudden vasodilatation. Then what happens? Diastolic pressure falls, coronary perfusion falls, PA pressure is higher than systemic pressure, and that's a very bad situation to be in. So you always try to manage the blood pressure first. Right? Because if you have vasodilatation, your curve shifts down. So that's going to be a big problem. So always remember the right side's venous return as well. So why not start inodilator? Tachycardia generally tends to be a limiting factor, but more importantly because blood pressure falls. But eventually, once you have stability, you can start. And really, to be honest, you can choose whichever you want. Vitamin, milrinone. A lot of people say that in high PVR, milrinone is good. Right? And that's what I generally do as well. Is it the right thing to do? I'm not sure. Guidelines or papers don't seem to favor one or the other. So now, final step, afterload management, the most weak step. So afterload reduction, what I usually tell people is don't be overzealous to intubate as fast as possible. A lot of patients actually start high flow nasal cannula if it's available to you, right? I try and optimize them, BP and everything before I try to intubate. Now, once you've intubated, in certain situations we try permissive hypercapnia, you may not want to do that. The amount of driving pressure, the amount of PEEP, you also want to be very careful, because if you go too high, you're going to be problematic as well. Now, vasodilators, if you want to give in the initial stabilizing factor, we tend to give direct pulmonary, because you don't want too much systemic vasodilatation. So if you have we have, for example, inhaled ileopros as well as nitro oxide, you can use one of these things to help. But generally, not so great. But a lot of these patients, once they start to stabilize, you can actually start your IV Velletri and your pH medications, usually with some norepinephrine or vasopressin to kind of stabilize the vasodilatory effect of systemic vasodilatation. So the approach is simple. Treat the underlying cause. Right? Don't do fancy things, treat the underlying cause. Optimize the preload, optimize the blood pressure and contractility, and then if possible, you can try and adjust the afterload. And it's based and grounded in physiology. Right? And of course, you have to do it in an expedient fashion. So for the pulmonary embolism case, honestly, we get an interventional team, we start anticoagulation. Preload, generally, you need to improve RV and coupling with the afterload, you give volume. Very rarely you remove volume for PE, acute PE. Right? You maintain the blood pressure. Do you think I'll put a PA catheter? No. Because I record the clot, the patients will be fine. So the PA catheter is not going to help me very much. The interventionist taking out the clot or giving thrombolysis is more useful. Right? And try your best not to intubate them as much as you can and do other things first. Pulmonary arterial hypertension, again, same thing. Generally, they need fluid removal. For those who are very chronic, slowly they're accumulating fluid. You realize that the LV is very squashed. I had an acute and chronic MR patient also. LV is very, very small. After surgery, everything went back to normal. So it's very important to understand that, right? And again, BP contractility, and try not to intubate if you can, as much as you can. Eventually, you need to get a pH folks inside as well. RV infusion easiest. Just give volume. Sometimes you need 3 liters of volume just to get the RV coupled. So this is a real case that I had, and I really want to put it in because it really perplexed me. Right, 72-year-old guy went for complex PCI, it was LED procedure, calcium modification was done, went VF and all that. Came back, one more VF, but no ST changes, nothing, was on dopamine because no central line at that point. And he was very stable, numbers were getting better, we didn't really worry so much, and suddenly it started to deteriorate. And we did the echo, we didn't think very much, his LV function was already low, but when we put in the PA catheter, we got a shock. We saw that the CVP to wedge ratio, very dramatic. Wedge pressure is very low, CVP is going up high, RV failure. And in hindsight, then we noticed the collaterals to the right side was knocked off. And that's why we suspect that the patient had such acute RV failure. There's no PE, nothing. So without the PA catheter, sometimes RV failure diagnosis can be missed as well. So this is one of those cases I had 3 months ago, quite interesting. I think there's not much time because a lot of us have to go home, but there is a new PE guidelines. Right, the PE guidelines is 2026 AHA. You can look at it. They have changed the way they stage the thing. So it is different from the ESC guidelines. Right, so I'm just going to skip this and I will just say PERT team is useful. Because if you have your plan A, plan B, plan C there and decisions are made early, generally the outcomes are better. And we had that experience in Singapore as well. Right, we stand by VA ECMO when we are doing PERT. We tend to use HFNC, and it's quite nice to see that the similar thing is found in the guidelines as well. Lytic therapy as well as thrombectomy is also there, but the data is not that great in C and D category. A lot of times it helps to reduce the pulmonary pressure, but in E then it seems to have some mortality benefit, but retrospective data. Right, and what we use is the Inari flow retriever. We also have the Penumbra, but we now use the Penumbra Lightning. So it's a 16 French. So I spoke to most of the interventionists, they think both are equivalent. ECOS we also have, but not as effective for very large clots. So these are the catheters that we have, and we have a PERT protocol. So I think this is I think my last slide, and so I do hope that people come up with the idea of the PERT protocol and try to have multidisciplinary management, get the ECMO folks in early, and I think that makes a big difference for the most critically ill patients. And with that, I'll end. Thank you.
very lucid presentation by Dr. Kamalesh Anbalagan. It is nice to have you twice on the podium. It's a dual delight for the audience. In the weekend, both the speakers talk very much on the both RV and LV failure. And so much has been the principle behind the cardiac failure, and both of you covered very nicely. For the past 2 hours, we have been engaged very nicely on the concepts and principles of congestive cardiac failure, and the situations and how to judiciously use mechanical support devices and so on. So much of overload with our brain with preload and afterload. Of course, we need not decongest them. We go home with very nice concepts about the congestive cardiac failure. I thank the Billroth team for choosing the tough area of patient management and giving clear insights into the management of cardiac failure. I thank, and I am privileged to be part of this academic feast. Thank you very much.
Thank you,
the
thank you
speakers
everyone.
and
Thank you.
Billroth team.
Thank you for your insightful session. We now come to one of the most beautiful moments of this gathering, celebrating and honoring our doctors for their outstanding contribution in medical field. They are not just healthcare providers, but the pillars of our institution, guiding us with their expertise and unwavering commitments to the excellence. It is our privilege. I invite Dr. Ilayaraja to the stage to honor the doctors with a heartfelt tribute to their dedication and remarkable achievement. I invite Dr. T. Parthasarathy, sir. I invite Dr. M.S. Ravi. I invite Dr. Shakti Suganya. I invite Dr. V. Magesh. I invite Dr. Paneer Selvam. Thank you, Doctor. I invite Dr. Vikram Vasagan. I invite Dr. Karthik. I invite Dr. T. Parthasarathy, sir.
In Kadalur, all prescriptions, sir. In Kadalur, all prescriptions goes with your name, sir. Whatever we see your name.
Thank you, Doctor. Round of applause to Dr. Vikram Vasagan, sir. Thank you, Dr. Karthik, sir. To deliver the vote of thanks, I invite Ms. Satya to address the gathering.
Good evening, everyone. On behalf of Billroth Hospitals, thank you for making today's program a resounding success. Today's exchange of ideas reinforces a legacy of precision built since 2003. Reaching milestones of 50,000 plus cath lab procedures and 10,000 plus CTVS surgeries is a true testament to the dedications of the experts in this room. A special thanks to our invited faculty, Dr. Kamalesh Anbalagan, and our esteemed chairs and speakers for their invaluable highlights. My deepest gratitude also goes to our own extraordinary team of cardiologists, cardiothoracic surgeons, and anesthetists. Your expertise is the backbone of our excellence. Most importantly, today we reaffirm that heart failure management is not just about procedure. It is about people, families, and their future. In a noble gesture, our chairman, Dr. Rajesh Jagannathan, has awarded 20 lakhs grant to the recipient of the heart transplant, Ms. Jayaparvadini, for her future. And in an act of visionary leadership, he will also be sponsoring her entire education. This is more than a grant. It is a personal promise from our chairman, Dr. Rajesh Jagannathan, to ensure that the little girl Jayaparvadini doesn't just leave here with a healthy heart, but with the wings to fly. For us, the success of surgery is measured by the life lived after it. We don't just mend hearts, we build futures. It is the spirit of hope that we celebrate tonight. To our delegates, thank you all for your time and commitment. I now invite you all to join us for dinner. Thank you.
Thank you, CEO Satya ma'am. Can go for dinner.